Hello everyone. In this video, we'll discuss few examples of arterial blood gas to help you understand the concepts better. You will not be able to have deeper understanding of ABG unless you use it on a daily basis. Practice is the key. Know that you will retain what you will practically apply. So let's get started. As we discussed in our previous lecture, that first thing is you look at your patient, get a history, perform exam, and then form a differential. Once you have a differential, then order a blood gas to see how it can help you further. Try to avoid looking at the ABG first and then the patient. Step 1 is to check the integrity of arterial blood gas using this formula. Most of the times the ABG's reading will be accurate, but on rare occasions the ABGs would not make any sense, so it's a good formula to remember. In ABG, when we interpret it, we use discrete numbers rather than a range. So normal pH is 7.4, normal PaCO2 is 40, and normal bicarb is 24. 5 steps of reading in ABG: check your pH, then look at your PaCO2, then look at the degree of compensation, calculate anion gap, and then calculate delta gap. So we have a 44-year-old presenting with shortness of breath. Blood pressure is 110/50, respiratory rate 30, heart rate 130. SATs are 100%. Patient is warm and well perfused, and chest X-ray shows pneumonia. These are your labs. The most important thing in interpreting ABG is that this is the minimum amount of information that you would need to interpret any ABG. That's your pH, PaCO2, bicarb, sodium, chloride, and albumin levels. If you have a very recent bicarb level from your basic chemistry, use that. And this is because your bicarb levels in your ABG are calculated bicarb and not the measured ones. Lastly, always look at your albumin levels, as you will need the information to calculate your anion gaps. The good thing is that this level does not change as rapidly, so you can use a day old albumin if you need it. So step 1, let's check the validity of this ABG. The hydrogen ion concentration in this case will be your 24 times PaCO2 divided by bicarb, that is 24 and 20, that gives you 28.8. And looking at this table, which compares their hydrogen ion concentration and pH, you come to a pH of 7.5, which is similar to the one in the ABG. So this ABG seems to be accurate. You can also use the other formula that we discussed in the previous lecture, that is your hydrogen ion concentration is 80 minus last 2 digit of your pH. In this case, your hydrogen ion concentration is 30. And looking at the table, the pH that you get is 7.5, which is similar to the pH that we started with. So this is an accurate ABG. So step 1 and 2 would be looking at your pH and PaCO2. Do not look at the bicarb at this stage, please. Since pH is more than 7.4, it is an alkalosis. And since PaCO2 is less than 40, that means you are blowing off CO2. So this alkalosis is from low carbon dioxide levels. So it's a respiratory alkalosis. Compensation for respiratory alkalosis is metabolic acidosis. So we know that drop in PaCO2 by 10 drops your bicarb by 2. So your expected bicarb is around 20. When you're looking at compensation from respiratory problems and you get an expected bicarb level, you need this bicarb level for further interpretation when you're doing the bicarb gap. To calculate the anion gap, always make sure that you look at the albumin levels. You know that the anion gap will drop by 2.5 for every drop in albumin levels. So in this case, the albumin level is 3. So the normal anion gap for this patient is not 12, it's 9.5. And we can see that anion gap, when we calculate it, it's 10, which is similar to 9.5. So there is no anion gap in this case. So for the bicarb or delta gap, we know that your baseline bicarb is 24 and we do not have an anion gap. So your expected bicarb should be 24. But when you measure this patient's bicarb, it comes out to be 20. So patient has lost 4 bicarb by some other means. So there is metabolic acidosis, which is a non-anion gap metabolic acidosis. And if you look more carefully, that 4 bicarb loss is coming from your step 3. Because this patient lost 4 during the compensation for respiratory alkalosis. So you can see that this matches perfectly, and this metabolic acidosis that you have derived from your delta gap step is nothing but the compensation for respiratory alkalosis. So this patient has acute respiratory alkalosis and with good metabolic compensation. Once you have interpreted the ABG, try to figure out what's causing the underlying acid-base problem. So in this patient, acute respiratory alkalosis is resulting from pneumonia. Most likely this patient has anxiety and stimulation of pulmonary receptors by inflammation in the lungs. Since his SATs are 100%, possibly hypoxemia is not the driving factor. So this is the next patient, 44-year-old with shortness of breath. His respiratory rate is 40, heart rate 140, blood pressure 110/50. He's warm and well perfused, lactic levels are 6, and chest X shows pneumonia. So these are his findings from ABG and basic chemistry. Step 1 is checking the validity of ABG, and in this case, hydrogen ion concentration is 24 times 25 divided by 12, that is 50. And looking at this table, H plus ion concentration of 50 corresponds to pH of 7.3, which is similar to the pH that is given to us. So this reading is accurate. So again, looking at step 1 and 2, look at your pH and PCO2. Do not look at bicarb. This pH is 7.3, which is acidosis. And since in respiratory acidosis, elevated CO2 is the reason for acidosis, in this case we see that the CO2 is actually on the lower side. This acidosis is not from respiratory causes, so it is from metabolic causes. So this patient has metabolic acidosis. Compensation for metabolic acidosis is respiratory alkalosis. So using your Winter's formula, your expected PaCO2 comes out to be 26 and his PaCO2 is around 25. So this patient is compensating pretty well with increasing his respiratory rate. His anion gap is 21, so he has anion gap metabolic acidosis. Last step, looking at the bicarb gap. Now again, look at your albumin, because this patient normal anion gap is not 12, because when you correct for albumin, his anion gap is 7 at baseline. So this patient has got normal anion gap of 7 and his baseline bicarb should be 24. As we discussed before, there is 1-to-1 relationship between anion gap and bicarb. If you add 1 lactic acid or any other negative ion to this mix, your anion gap will increase by 1 and you will lose 1 bicarb to maintain the electroneutrality of the solution. If your anion gap increased from 7 to 21, you should have a bicarb drop from 24 to 10. But this patient, when you measure it, it comes out to be 14 and not 10. So this patient must have gained 4 bicarb from some other process, which is not accounted by anion gap. So there is a metabolic alkalosis as well. So this patient has anion gap metabolic acidosis with normal respiratory compensation and an acute metabolic alkalosis. His anion gap metabolic acidosis is likely resulting from lactic acid production from pneumonia and sepsis. His metabolic alkalosis is possibly coming from depleted intravascular status, unless you get some history of vomiting or if the patient received Lasix in the ER. Let's do another example. This is an 18-year-old, comes with altered mental status. His blood pressure is 110/50, respiratory rate is 40, heart rate 130, and SATs 100%. He's warm and well perfused, chest X-ray is clear. These are the findings from ABG and basic chemistry. Going from steps 1 and 2, step 1 shows that it is alkalosis, and since your PCO2 is on the lower side, that means this alkalosis is caused by respiratory means. So the primary problem is respiratory alkalosis. Compensation for respiratory alkalosis is metabolic acidosis. So we know that drop in PCO2 by 10 would cause drop in bicarb by 2, so your expected bicarb should be 19. His anion gap would be 25, so he has an anion gap metabolic acidosis. Since his albumin is 4, his normal anion gap should be 12 and his baseline bicarb should be 24. So his anion gap of 25 should result in bicarb of 11 because there is 1-to-1 ratio between anion gap and bicarb. But when you measure this patient's bicarb level, it is 14. So this patient got 3 bicarb from somewhere else, so you would expect that he has some underlying metabolic alkalosis as well. And here we have to look at the step 3 again because his expected bicarb was 19. If you really look more carefully, he lost 5 bicarb because he was compensating for that respiratory alkalosis. So in fact, he really gained 8 bicarb from somewhere else instead of 3. So if you look at this figure on the right, he gained 8 bicarb ions from some other metabolic alkalosis process. He used up 5 for that compensation, and 3 is the one which you are getting from calculating the bicarb gap. So this patient has quite a bit of acute metabolic alkalosis of gaining 8 of bicarb and not just 3. So this patient has acute respiratory alkalosis with acute metabolic compensation. He also has anion gap metabolic acidosis and acute metabolic alkalosis. On further history, you get that he has been vomiting, has abdominal pain, and has tinnitus. So this is a classical case of aspirin overdose. Aspirin can cause stimulation of the respiratory center, thus resulting in acute respiratory alkalosis. The lactate and salicylate are negative ions and will cause anion gap metabolic acidosis. Aspirin causes gastritis and stimulates vomiting. So that's where your acute metabolic alkalosis is coming from. And tinnitus is one of the common side effects of aspirin overdose. So you can see that this patient has multiple acid-base problem, and if you follow those 5 steps, you should be able to identify each one of them individually and come to a diagnosis like this one. So steps to reading any ABG is go through the 5 steps, and in this order, look at your pH, then look at your PaCO2. Please do not look at the bicarb, and I want to stress this fact. Check the degree of compensation, then calculate your anion gap, and then calculate your bicarb or delta gap. Keep on practicing these 5 steps on every ABG that you see. And once you get comfortable, go for my next video where we discuss a little bit more complicated topic of chronic compensation. Reading ABG is pretty easy if you follow these 5 steps. Again, the most important thing is practice. Look at your ABG and do these 5 steps. Do not take any shortcuts. Once you start interpreting ABGs with due diligence, you'll get much better at it, and you will reach a point where you don't have to do all those 5 steps anymore, and the things will become a second nature to you. Thank you.